Hello students, in today's lecture we are going to talk about a very important drug. This drug has been asked in so many times in various MCQ about the effect and side effect of this drug, and that is lithium. So lithium is called the mood stabilizer. It is called the mood stabilizer. Why? Because it is effective in both mania as well as depression. Mania usually doesn't occur as alone. It is seen as a part of bipolar mood disorder where the mood keeps changing from mania and depression. Depression can occur as alone, which is called major depressive disorder. Both diseases are totally different. They have a different pathophysiology, and lithium has a different mechanism by which it is useful in both the disease, and that is why it is useful in both extreme of the condition, and that is why also it is called a mood stabilizer, because it is effective in both mania as well as depression. Let's see one by one what is its mechanism. First of all, mania. The problem in the mania is there is increase in concentration of the calcium. There is increase in concentration of the calcium inside the brain. So when calcium concentration inside the brain increases, it leads to increased stimulation of the brain cell, and that is responsible for the mania. Now, why this concentration of the calcium is increased? Because there is one second messenger system which is overactive. There is two main second messenger system which is found with the G protein coupled receptor. One is CAMP and second is IP3DAG. So this IP3DAG pathway is overactive, and increase in IP3 lead to increase in calcium. Now, to understand the mechanism of the lithium, we need to understand that how this IP3 is recycled. Phosphate is easily available, but inositol is in very limited amount. So this inositol in IP3, that is inositol triphosphate, this inositol is recycled. Phosphate is removed one by one to convert it into inositol, and again reattach to convert it into the phosphoinositol biphosphate, and this cycle keeps repeating, and which ultimately lead to increase in calcium concentration. It is also occurring normally, but when this system is overactive, we need to control it, and that is what lithium does. Lithium interferes with this recycling of inositol. So inositol cannot be recycled, and overall concentration of inositol decreases. So this overactive system comes into the check. Overall concentration of the calcium again becomes the normal, and that is how it controls the mania, by interfering with the recycling of inositol. Clear? Let's see how it is effective in depression. Now, in case of depression, according to latest theory, there is substance called BDNF, brain derived neurotrophic factor. This BDNF is basically required for the neuronal connection, which is called neuronal plasticity in the scientific term. This neuronal plasticity is very much important, and it is now current hypothesis that because of lack of this neuronal plasticity, there occurs a depression, and reason is there is decreased amount of this BDNF, brain derived neurotrophic factor. So this BDNF decreases inside the brain, which lead to depression. How this BDNF is metabolized? It is metabolized by enzyme called GSK3B, glycogen synthase kinase 3B. It is not Jasi Krishna, it is glycogen synthase kinase 3B. So this enzyme is responsible for inactivation of BDNF, and lithium inhibits this GSK3B. So BDNF is no more inactivated. Overall concentration of BDNF inside the brain increases, and it improves the mood. That is the theory how lithium is effective in the depression. Clear? So in case of mania, it controls the increased amount of the calcium. In case of depression, it improves the BDNF concentration. Now, I generally do not talk about the pharmacokinetic, as it is not very much important in many of the drugs, but in case of lithium, it is important. Lithium is the drug with a narrow therapeutic index. It is a drug with narrow therapeutic index. That means the concentration at which it is effective and concentration at which it is toxic is very narrow, and we have to monitor it. So let's see about the pharmacokinetic. First of all, it has 100% bioavailability. Almost all the drug given by oral route get absorbed. It is also a CNS drug, and any CNS drug has to reach to the brain, so it has to cross the blood-brain barrier, so it has to be a highly lipid soluble and very large volume of distribution. And this lithium is interfering with the second messenger system, so it has to go inside the cell, so it is very large volume of distribution, and when there is a very large volume of distribution, it takes lots of time to get out. So its T half is 24 hours. Its plasma half-life is 1 day, and it has a very narrow range of safety. The therapeutic concentration is in the range of 0.5 to 0.8 milliequivalent per liter in the blood, and when concentration goes about 1.5 milliequivalent per liter, the toxicity starts. So it is just a double of the higher dose range. So its therapeutic window is very narrow. So we have to keep checking the concentration of this drug whenever we change the dose. So when we can change, if we have changed the dose, when we can monitor, it requires the 5 half-life. So in this case, it will be 5 days. So if we change the drug, we have to measure the concentration after the 5 days of giving lithium. Whenever we change the dose, we have to measure it after the 5 days. Okay, and on the 5th day, it has to be measured 12 hours after the last dose. That is where the trough concentration is seen, and at that time there will be ideal time to measure the lithium concentration. It should be between 0.5 to 0.8 milliequivalent per liter of the blood. Now, which are the toxicities which occurs with the lithium? So many toxicities occur with the lithium because it is interfering with one of the basic cell process. So many toxicities are seen with the lithium. You can remember the toxicity by mnemonic Lithium. So let's see what it stands for. First of all, L for leukocytosis. It is a drug which increases the WBC count. It increases the WBC count. Most of the drugs usually decrease the WBC count, but this drug increases the WBC count. That is the first toxicity. Second thing, it is teratogenic. If given to the pregnant mother, it can produce various abnormalities. So most important to remember is one is Epstein anomaly. It is one of the anomaly which is associated with the drug, and the most common drug is lithium. Epstein anomaly, where there occurs tricuspid ataxia, there can occur a tetralogy of Fallot's, etc. And a baby which is born is very hypotonic. It is called floppy baby syndrome. So two teratogenic effect or two pregnancy related effects seen with the lithium: Epstein anomaly and floppy baby syndrome. That is T for teratogenicity. Now H, hypothyroidism and hyperparathyroidism occurs. Why hypothyroidism occurs? Because it interferes with the release of the thyroid hormone. So hypothyroidism occurs, and it also produces the hyperparathyroidism. So overall result will be increase in the calcium concentration inside the plasma. It will increase the calcium concentration by hyperparathyroidism. I is for insipidus. Diabetes insipidus occur with the use of lithium. How it is producing diabetes insipidus? In the collecting tubules, there are special sodium channels through which sodium enters inside the collecting ducts, cell of the collecting duct. The same sodium channel which is blocked by sodium channel blocker or ultimate target of this spironolactone, that electric derived sodium channel, E-next sodium channel, through which the lithium also enters inside this cell. So once they enter, it cannot escape out of the cell, and once they inside the cell, they interfere with the function of ADH. So it doesn't allow the water to reabsorb by interfering with the ADH, and it produces the diabetes insipidus. So what is the treatment? If we can block the entry of the lithium inside the cell of the collecting ducts, then we can treat it, and that sodium channel is blocked by amiloride. So amiloride is the treatment. We can give amiloride, which will prevent the entry of the lithium inside the cell and prevent its interfering effect with the ADH. So I for diabetes insipidus. O for obesity. It produces obesity, and patient should not go on the diet, otherwise there can occur a hyponatremia. So obesity can occur and patient is advised not to go on the diet. Seizure can also occur in the higher dose. Arrhythmias can occur as it interfere with the conduction, particularly in a very high dose. It can produce a AV block, T wave, prolongation of the T wave, and then AV block can occur with this use of lithium. And the ataxia usually is monitored because of it is indicative of the sign of lithium toxicity. And apart from this usual side effect, this side effect, anorexia, nausea, vomiting and diarrhea, particularly nausea and diarrhea, vomiting and diarrhea, are very common, and they are the first sign of the lithium toxicity. So usually we do not consider this GIT symptom very seriously, but in case of lithium, they are good indicator of lithium toxicity. So this vomiting and diarrhea as well as this ataxia and CNS sign are the first sign of lithium toxicity. It should be monitored in the patient taking lithium. Now, so lithium is so much toxic that there are alternative therapy should also be there. So there are some alternate therapy available, but ultimately patient is not responding to them. We have to go to the lithium therapy. So which are the alternate therapy available? In case of acute mania, sedative plus antipsychotic are the treatment of choice. Why? Because lithium takes time. It takes almost 2 to 3 weeks for lithium to take its full effect. So when patient is in acute mania, patient is very aggressive, and patient need to be calmed down and controlled immediately. In case of mania, patient loses the sleep, patient become there is very severe insomnia in patient of the mania. Patient may not sleep for the weeks, and they become very irritable. So sedative plus antipsychotic is the first choice treatment in case of acute mania. Once the patient comes under the control and lithium also started, it will take its effect. But initially we have to calm down patient with the sedative. In the prophylaxis, apart from the lithium, the alternative therapy which is effective is sodium valproate, which is anti-epileptic drug. Sodium valproate can be given, and it can also be given as add-on therapy when patient is not responding to lithium alone, and lithium can also be given as add-on therapy when patient is not responding to the valproate alone. Then antipsychotic drug, particularly atypical antipsychotic drug, has also been in the use in the case of mania, because they are having little bit less side effect as compared to the lithium. So atypical antipsychotic are also used in the treatment of mania. And last, the lamotrigine, again a anti-epileptic drug, can be used in the bipolar disorder. It is particularly useful in controlling a depression, not a mania phase, but in the depression phase, which is if not responding to the lithium, lamotrigine can be tried. So that was all about today's lecture. Thank you.